I wanted to go over this EEG because it demonstrates a very important point, but before I give it away, just look at the EEG over here, and I'm going to have you focus on this area right here. What does this make you think of? And this is a bipolar montage. This is the left side. This is all the odd numbers is the left side. All the even numbers is the right side. So what does this make you think of? Okay, so hold that thought. Now we're going to move forward. And this is an EEG. I'll just give you a little bit of a story. This is a 5-year-old girl that was brought to the medical attention when during her nap she sat up and started moving her lips. So that was her story. So she's 5 years old, and she has this abnormalities on her EEG. So right here it's a little bit more obvious. What we're seeing here is a spike and a wave, spike and a wave, spike and a wave. And if you count the number of spikes that you get within a single 1 second epoch, it's about 3 per second roughly. So this is kind of 1 second. So 1, 2, 3, 3 hertz spike and a wave. Now the question is, what is this? Are we dealing with one-sided lesion that's spreading really rapidly to the other side? In this case it would be to the left side. Or are we dealing with the bilateral process? So this is another demonstration, about 3 seconds of this run of 3 hertz spike and a wave. It may be helpful to reformat it to see a little bit better the activity. Let's go back to bipolar now. So here she's awake. EEG tech is mentioning she's talking. If you look at her posterior dominant rhythm, you can count it. For her age, she should be already above 8. So she's pretty up there. Alpha rhythm is easier to visualize after a person blinks or when they close their eyes. In this case, of course, she's moving around. She's a very active girl. So it can be a little bit more difficult to get a good alpha in this instance. But this is probably the money shot right here. Let me see if I can center it a little bit better. Maybe a little bit difficult. So this one right here is showing what appears to be initially, on the first glance, sort of a more higher amplitude that's on the right. So this would make you wonder whether you're dealing with a generalized process. However, I would challenge that, because if you actually went and you looked at the referential, which is a good one to look at if you're thinking about generalized epilepsies, what you're going to see here is that in those leads where you have A1, where you have A1 electrode, there's almost like you could almost say that this is flat. So what's happening here is this is what's called an active A1 electrode. So A1 is supposed to be a reference electrode, and ideally you want it to be silent. You want it to be on part of the brain that's not picking up a lot of electrocerebral activity. However, it's not always possible, because A1 is sort of right behind your ear where your temporal lobe is. So if there is activity there and it will pick it up, then when you do the referential, instead of being referred to sort of a mute electrode, you're actually subtracting a difference between the two. And because A1 is actually active, then you get the cancellation effect. And that is why here on the left hemisphere, it looks as if you don't have as much of a generalized spike and wave activity comparing to the right side. So this does not mean that this is right side predominant with quick spread to the left. It just means that there is a cancellation effect from the active A1 electrode. So I just wanted to use this as a good example of that, because you see this 3 hertz spike and wave cases like generalized absence epilepsy, and it's usually very beautiful, textbook-like, but this just shows to you that it doesn't always look that way in the real life. So this is again what it would look like on the bipolar montage, which we normally use to read most of the EEGs. And again, you can appreciate a much higher amplitude and much more clearly sort of identified pattern of the 3 Hz spike in a wave, spike in a wave. I think this was the last time that she had that generalized discharge, if I remember correctly. Oh, no, I'm wrong. There's another one. This one's again lasting about 2 seconds. This one is actually pretty nicely developed on the left hemisphere, so this one does look pretty generalized. A clue that this is generalized rather than a focal, let's say frontal predominant epilepsy with quick generalization, the clue is that you have a very abrupt onset. Like you see how you go from pretty much normal posterior dominant rhythm right here to this spike in a wave, and a very rapid return to your prior baseline a posterior dominant rhythm. This is what you will have with patients with generalized epilepsies, such as absence. It kind of makes sense clinically speaking too, where they go from this staring spells and then they go right back to their baseline. There's no postictal period, which you would expect with partial epilepsy if it were to have a partial onset and then affect, of course, complex partial if it affects your consciousness. And this is it. Unfortunately, they did not do hyperventilation here. She didn't want to. But for this type of cases, hyperventilation would actually help because it would elicit much more prolonged of a response, and in some cases it would elicit an actual clinical event, a clinical seizure, which would correlate on the EEG with generalized 3 Hz spike and wave discharges. And that's it. Thank you for your time.